The following podcast is part of a certified educational activity titled Under Pressure to Improve: How to Unlock the Power of Antibody Drug Conjugates to Transform the Treatment of Lung Cancer. Access the entire activity and complete the post-test at peerview.com/YXT860. Downloadable slides and practice aids are also available.
Welcome, everybody, to an early morning edition of Under Pressure to Improve: How to Unlock the Power of ADCs to Transform the Treatment of Lung Cancer, where we turn dry educational content into a wonderful game show. So I hope you'll enjoy this. This is our second run of this, and we've refined it. So this is good news. Pleasure to have you here, and pleasure for me to just briefly introduce the esteemed faculty we have. We have Dr. Becca Heiss from Mass General Hospital, Dr. Charu Agarwal from University of Pennsylvania, and then we have Stephen Liu from Georgetown, and they will all be playing a dual role as game show contestants, and then they will shift to being panelists and talking about the educational content that particular question was related to. I've tried to make these questions impossible to answer, and hopefully we'll have negative points for all contestants. Nobody's a winner on this ADC. We all want to be in the negative. There's no final round here of Jeopardy, so everyone, we continue to the end, despite the points. So our goals for today, really, there's a missing bullet point. Number one is to have fun. Two is to augment the knowledge of different ADCs and expanding evidence supporting their use in lung cancer, and then equip you with the skills to optimally integrate the approved and investigational ADCs in the lung cancer treatment arsenal. And as I mentioned to you, again, much of the data that we're going to be presenting hasn't even been published yet. This is very counter to how we used to present slides and the content that was available. So yes, some of it has been published, but the field is moving so quickly that we really we don't get a lot of opportunities to hit the pause button. And this is a nice time to do that and go over the data that we have as of December 2023. So this is important. Everyone, please pay attention to the peer pressure rules, and I mean that to the contestants. Pay attention here. Wake up. These are the rules here. So the first to hit the buzzer will have a chance to answer. We've refined the buzzers a little bit, and they're good to go here. Please don't try to be nice to your buzzer. No hard hitting. Just a soft touch will work here. Okay. Contestants who answer correctly will receive 100 points. Contestants who answer incorrectly will be deducted 100 points. High risk, high reward. If a contestant answers incorrectly, the other contestants have a chance to steal. And I would say in that scenario, once again, please do not assault your buzzer. Just a soft touch on there will do the trick. Good. Here we go with the first question. Which of the following classes of compounds is not a class? Who was there? Is it Charu? No, I'm sorry, Becca. Sorry, Becca.
DNA cleavage agents, I'll say.
Incorrect. Stephen Liu timed the buzzer correctly.
4, alkylate.
That is correct. We've had Becca just very good. Round of applause for Stephen answers the first question. Okay, that's the last question he'll get right. Becca, don't think this hard. This actually was missed the first go around too. Very difficult question. And I'm going to go over the basics of ADCs. I have the pleasure of being your moderator and the panelist here. We'll just spend the next maybe 5 minutes on the basics of ADCs. These are the new kids on the block for lung cancer. The operative word there being lung cancer, because they're not new kids on the block for other solid tumors, including triple-negative breast cancer, urothelial cancer, and others. Of course, you have the antigen target and the receptor. You want that antigen to be expressed selectively on the tumor and obviously absent in normal tissue. You need the antibody that has high affinity and avidity for target antigen, a long half-life, and it has to have the ability to conjugate to the particular warhead and to the linker. In terms of the linker, there are both non-cleavable and cleavable linkers. I think there's a lot of confusion about these linkers and what they mean. Non-cleavable is pretty clean in that it needs lysosomal degradation. You need that ADC to be internalized by the lysosome for the payload to be released from the monoclonal antibody. Cleavable is a little bit more flexible in the ability for the warhead to disassociate from the monoclonal antibody. You need acidic or a reductions-like environment, or you need to have proteolytic enzymes that can cleave that linker. You want that sweet spot with the linker. You want a linker that's able to hold on to the warhead in the circulation, but then release it once it gets to the tumor or the tumor microenvironment. And here we go with the payload, the classes of payloads, the microtubule inhibitors, the DNA damaging agents, and the topoisomerase inhibitors, not the alkylating agents. They need to, of course, be amenable to linker attachment. They need to be stable. So all of this really comes down to synthetic biochemistry. This is really important. Very difficult to develop these compounds and really sophisticated biochemistry and how these drugs are developed. There's multiple mechanisms of action for ADCs, and I think we just have a nascent understanding of how these drugs truly work. Yes, there's that beautiful pictorial of the monoclonal antibody binding to the antigen. There's internalization and the warhead is released. That's quite clear in much of the literature that permeates and percolates throughout what we're seeing now in publication. But there are other mechanisms of action. The bystander effect, I think, is very important, where these drugs release, or the monoclonal antibodies release the ADC and the target antigen, the cell that has the target antigen, and then there's permeability of the warhead to destroy adjacent cells without the antigen. And then there's perhaps just as important, ADCC, or antibody-dependent cellular cytotoxicity, where the monoclonal antibody binds to the antigen, but the FC portion of the monoclonal antibody is able to engage the adaptive arm of the immune system. So once again, we're still learning. If it was as clean as the monoclonal antibody binding to the antigen and then just internalizing and releasing the warhead, then IHC overexpression would predict response to these drugs in lung cancer, and they haven't yet, and we'll talk about that at the end. Just a quick mention on DAR. DAR is the average number of payload moieties attached to each monoclonal antibody. They range from 2 to 8. The higher the DAR, the more likely, the more efficacious these drugs may be, but the more toxic they may be. Like the linker, the DAR, there's a sweet spot. Can we get the appropriate amount of DAR that gives you high cytotoxic kill, but does not have untoward side effects? Interestingly, the higher the DAR, the more likely you may be clearing the drug by the liver. So there may be counterintuitive here. The more DAR may be cleared by the liver, making these drugs less effective. So ADCs are more than some of their parts. Again, I think we're still learning how these drugs work, who they're going to be leveraged for in our clinic. And I think that once again, we are still learning about these drugs and who they're for. And so look forward to the next 5 years to see how these drugs get leveraged, not only in clinical trials, but in our clinical practice. I think we're ready for the next question, guys. Here's the scores right now, just in case you're interested. Which HER2 alteration is most frequent? Pay attention. In non-small cell lung cancer, HER2 exon 20, HER2 amplification, or HER2 overexpression? Pay attention. Which HER... Dr. Agrawal.
I'm going to say HER2 overexpression.
Very good. Very well. Round of applause for Dr. Agrawal. Always attention to detail, Dr. Agrawal. And so, Stephen, I'm going to turn this over to you. Oh, whoops, sorry. We have another question? My apologies. Ready? Stephen, ready?
Yeah.
Okay. All right. What was the intracranial response rate observed with the I don't see who's... Dr. Heists.
I am going to say 50%.
Coming back to form and life, Dr. Heists. Very good. Well done. Round of applause for Dr. Heists getting on the zero. Okay. This is a barn burner here. Stephen, We're going to turn it over to you to talk about the HER2 targeting ADCs.
Yeah, so HER2 is a common target throughout oncology. In fact, this family of receptors, ERB, is really central to cancer. Reminder that EGFR is ERB1, and this is a family of receptors that have some common structural features, often activated in multiple cancers, including in non-small cell lung cancer, and central to a lot of critical signaling pathways. When you think of HER2 specifically in non-small cell lung cancers, Dr. Agarwal mentioned we do see overexpression a little bit more frequently, but we can see amplification, we can see mutation, and this is really a setting where it's important to pay attention to the details. We think of HER2 in cancer, we often think of overexpression amplification in breast cancer, but in lung cancer, it is the mutation that's the relevant target. And as you can see from this Venn diagram, that they don't always strongly correlate. And so these really are quite different. HER2 as a target in lung cancer has had a little bit of a rocky path. The original tyrosine kinase inhibitors, pan-ERB kinase inhibitors like afatinib, dacomitinib, in vitro, preclinically, we'd expect them to be very active against HER2 mutant lung cancer, but in clinic, the response rate's really around 10% or less. It was the antibody drug conjugates that gave us our first breakthrough in HER2 mutant lung cancer, showing response rates about 50%. Now, the initial TDM1 gave us a PFS of about 5 months. With TDXD, we're starting to see the longer durations of response and clear activity. This is a schema of trastuzumab deruxtecan. This has a drug-antibody ratio of about 8, a very high potency payload, the exatecan molecule. And this was first studied in Destiny Lung 1. And so this was a single-arm multi-cohort study looking at TDXD, which had already been established as an active agent in breast cancer. Let's try it in lung cancer. And really a search for biomarker. As it continues, we look at overexpressing and we look at mutant. Now, as Dr. Levy mentioned, when you think of how antibody-drug conjugates work, it makes sense for IHC expression to be the perfect predictive biomarker, but it didn't turn out to be the case in HER2. Really humbling and a reminder that we don't exactly know how these drugs work. But in HER2 overexpressing, there was activity, but the response rate about 25%. In HER2 mutant, we saw about double the response rate. And that's really the path that this drug has taken. The response rate here over 50%, a very impressive waterfall plot, clear activity, though this was balanced with some toxicity. And so at this dose in Destiny Lung 1 at 6.4 mg per kg, we saw a lot of toxicity that aligned with chemotherapy. You see nausea, you see alopecia, cytopenias, but our biggest concern here was the rate of interstitial lung disease, at really what I think an unacceptable high rate of 28%. But we have an active drug, and so maybe we're just giving a little bit too much. That led to Destiny Lung 2, a randomized study exploring the dose, optimizing that dose. We have a 2-to-1 randomization to 5.4 mg per kg versus 6.4. And what we saw is that lower dose really maintained activity. We see response rates of about 50% in both arms, while numerically, the PFS a little bit longer in the higher dose. If you look at these KM curves, they really track pretty similarly. We're looking at pretty similar efficacy. We can give a lower dose without sacrificing much in terms of efficacy, and that median duration of response, 17 months. These are durable responses, frequent responses, and as we'd expected, we did see very high rates of clinical benefit, a very impressive waterfall plot, the confidence that if someone comes into my clinic with a HER2 mutant non-small cell lung cancer, I can deliver a drug like trastuzumab deruxtecan and not hope for a response, but expect a response. And at this lower dose, we did see better safety. Lower rates of adverse events, specifically with drug-related ILD, we're down to 13%, primarily grade 1, grade 2. ILD is still something we need to watch for, to consider, but a much lower rate of ILD, maintaining that efficacy. This is our approved dose, 5.4 mg per kg every 3 weeks in previously treated HER2 mutant non-small cell lung cancer. Some interesting data presented at Madrid about a month and a half ago at ESMO 2023 looked at the activity of trastuzumab deruxtecan in the brain. Now, we've always been taught large molecules like monoclonals, bispecifics, ADCs, they can't penetrate that blood-brain barrier. We don't expect them to work in the brain, and we're having to unlearn that because we're seeing clear signals across multiple ADCs that these drugs can work in the brain. This was an exploratory pooled analysis between the Destiny Lung 1 and Destiny Lung 2 group, patients with advanced non-small cell lung cancer with brain metastases, specifically focusing here on those with untreated and measurable brain metastases. And what we saw here, as Dr. Heiss mentioned, the response rate at that approved dose of 5.4 mg per kg, 50%. Disease control rate, 93%. This is in measurable brain metastases, and the duration of response, 9.5 months. In fact, if we look at cross doses, 78 to 86% of patients with measurable brain metastases had a decrease in the size of those brain metastases with trastuzumab deruxtecan. This drug works in the brain, giving us that confidence and maybe protecting the brain in other patients that don't have established brain metastases. But just a quick throwback to safety, that is our top concern here. These 5 S's can help us address ILD. 13%, it's not zero. It's not most of our patients, but it's important that we're aware of it. And so here are the 5 S's to kind of remember. Drug-related interstitial lung disease. We want to screen patients. In the previously treated space, if patients are coming off chemo-IO or immunotherapy, we want to be sure they don't have pneumonitis to start with. We want to scan with a high-resolution CT with any symptoms, hypoxia, the first signs, and there's really synergy with the team. We want to make sure we're educating our nurses, our infusion team, our colleagues, our emergency room physicians, but also the patient, their caregivers. If they're feeling suddenly short of breath, don't wait 3 weeks to tell me, give me a call right away. And if there's a suspicion of ILD, suspend treatment, give steroids. That's going to help us avoid any bad outcomes. And I think that sort of brings us up to speed with where we are in terms of targeting HER2 with ADCs.
Great overview. A lot of questions coming in here. I'm going to open it up to the rest of the panel here too, just to talk about the HER2 space. Stephen did a nice job going over this. The whole IHC story, where we're not seeing IHC predict response in this space like we are with HER2 mutations. Interestingly, I don't know if you saw this, and maybe you didn't see it because Stephen hadn't tweeted it out yet. I don't think you've tweeted this out. The pan-tumor Destiny study has shown that the higher the IHC for HER2, the more likely you are to respond to trastuzumab deruxtecan in multiple tumor types. And there's not a lot of lung patients in that study. We're not seeing this in lung. Becca, your thoughts on this and what's going on?
So it's interesting. That data was presented at ESMO this past year, right? This past month, maybe. And so in that data set, if you looked at the 3+ IHC across multiple tumor types, the response rates were quite high. I forget the exact numbers, but they were 60, 70% or something like that. If you looked at 2+, there was still a reasonable response rate, maybe more in the 20 to 30 to 40% response. I think the jury's still out on that. And the actual number of patients with lung who were reported in the IHC cohort still is pretty small. There aren't that many patients who are 3+ in that cohort. So I think it would be interesting to see updates on that data. And it's possible that maybe 3+ matters more than 2+. I don't know. Certainly in the pan-tumor it did.
Do we think in lung, are we ready to abandon IHC in lung? Or are we still thinking maybe it's worthwhile? We're going to look at, of course, in trials. Do you think that IHC for HER2 still has some traction in lung?
I think so. 25% response rate isn't nothing.
Right.
And then if there is actually an enrichment in the 3+, which I don't believe there were that many patients with 3+ in what's been reported so far, then, maybe that number gets significantly higher and maybe we're more excited.
Charu, Stephen talked a lot about the interesting signal we saw intracranially. When we started with these drugs, I would have thought that ADCs have no business crossing the blood-brain barrier. I mean, these are large molecules, but yet we've seen some interesting updates from the HER2 ADC efforts. We've seen some interesting updates from patritumab that you'll present. What's going on here?
Yeah, so I think this is clearly an unmet need. Many of our patients, in the second, third line setting, when they're getting exposed to these agents, either develop new brain mets or they have asymptomatic, untreated brain metastases when we begin these therapies. So just the fact that we are seeing intracranial responses, irrespective of being treated, I think it's fantastic for our patients. Can I explain the mechanism of action? Not really. I wonder if you can. I think it's more to do with potentially a bystander effect and the ADCC component that's helping with this intracranial activity. But I think this is a theme that we're seeing across ADCs, with not just with HER2, but with HER3 agents. I think there's some preliminary activity with TROP2 in breast that we haven't quite seen in lung yet. So I do think that this is going to be extremely beneficial to our patients.
Yeah, I think we're just scratching the surface here. We start to see these signals, and then we have to explain them scientifically. Who would have thought that giving these drugs would elicit responses in the brain and maybe negate the need for a radiation oncology consult the way we do with TKIs? Stephen, you talked about ILD and the importance of looking for ILD. Do we know if the mechanism of ILD is different with ADCs than IO? And do we think that there's a particular patient we have to be mindful of when putting on these drugs, screening for ILD? Is there prior therapies to look at, prior radiation?
Yeah, I think we're still learning about a lot of these risk factors, identifying the patients at risk. There does seem to be some link to payload, and it may be specific markers that might be expressed in certain normal lung tissue. I think the big key here is that you want to make sure you're going in clean.
Yeah.
If you're going in with pneumonitis and you certainly have a higher risk of developing worsening ILD. But I think the big key, it's not a barrier to use. It's really just awareness, making sure that we educate patients. Overall, these are active, potent drugs. They're beneficial. We just need to be aware of the risks, make sure patients know, so that if someone does develop ILD, we recognize it early, we intervene early, and really rescue that.
Yeah. I think the proactive management of a lot of these AEs that we're seeing with ADCs is going to be important. Okay, let's shift and get ready here. Buzzers ready, hands ready. Next question. What was the primary endpoint of a Hera Lung O2 study? Objective response rate, toxicity, PFS, or OS? Pay attention to the question. What was the primary endpoint of the Hera Lung O2 study? Objective response rate, toxicity, PFS, or OS? A lot of thought going into this. I'll read it again. Dr. Agarwal.
Progression-free survival.
Very good, very good. Round of applause, please. I'm not going to ask again. Every time, just the cue is clap, okay? Thank you. This is great. This is very appropriate. Let me see if there's one more question here before I turn it over to Dr. Agarwal here. Nope. Dr. Agarwal, turn it over to you to talk about HER2 targeted ADCs.
All right, great. It's going to be a tough act to follow, Stephen. But we're going to talk about HER3 targeting ADCs. And this is a target that's also in the HER family. I'm going to talk about patritumab deruxtecan, a lot of data coming out at the previous meetings, an ADC targeting HER3. It's being positioned mainly as an ADC in the post-EGFR progression setting. As with other ADCs, this is a fully human anti-HER3 IgG1 monoclonal antibody, and it is linked to deruxtecan, which we've heard about before with trastuzumab deruxtecan. And this also has a pretty high DAR of 8. This has been evaluated in lung cancer as well as metastatic breast cancer and colorectal cancer. Similar to HER2, HER3 is also overexpressed in lung cancers, 83%. And I think this is important because HER3 may be an escape mechanism for resistance patterns following use of EGFR-directed TKIs. So Hera Lung O1 study is something that was presented recently at the World Lung Conference in Singapore this year, looking at the activity of this drug in the third-line setting. So patients with EGFR mutant lung cancer could come on to the study after they had received a prior EGFR TKI and platinum-based chemotherapy. They amended the protocol later to include only those patients who had progressed on a third-generation TKI, such as osimertinib. Patients were randomized. After an up titration, patients were actually received fixed dose of 5.6 milligram per kilogram of patritumab dosed every 3 weeks, and a total of 225 patients were enrolled with a primary endpoint of overall response rate. Overall, median characteristics are what we expected for these patients, predominantly female, 59%. And I think it's important to recognize that about 51% of the patients coming into this study did have a history of CNS metastases. And as you can see at the bottom, prior third-generation EGFR TKI receipt was 93% of the patients. This is related to the fact that the study was amended shortly after initiation to include only those who had received third-generation TKI. So we're looking at a third-line study. And what we are finding is that this drug is pretty active. If we look at any prior EGFR TKI and receipt of platinum-based chemotherapy, we're seeing an overall response rate of about 30%, which is similar to the subset that received a third-generation TKI. Duration of response about 6.5 months, and an overall survival of about 12 months. And you can see in the forest plot on the right that we're seeing activity pretty much across age, sex, as well as receipt of prior regimens. Irrespective of the resistance mechanism, we are seeing activity. So be it an EGFR-dependent resistance mechanism or an independent mechanism or even an unidentified mechanism, as you can see in this waterfall plot, we're seeing a few complete responses, but a lot of partial responses, as well as stable disease, which may be actually very clinically meaningful in this setting. HER3 expression, we've been talking about biomarkers. Is HER3 expression related to response rate? And it seems that if you have an H score which is high, you tend to see CR, PRs, and SD, or your stable disease, sort of congregated within the high HER3 membrane H scores. But you can see some responses even with the low H score. So I think this is not going to potentially move forward as a biomarker to test and treat. I think we're seeing responses across different resistance mechanisms as well as different H scores. Safety profile, I think it's important to recognize that the ADC safety profile largely relates to the payload. So with deruxtecan, we can see nausea, we can see myelosuppression, so thrombocytopenia being the predominant myelosuppression mechanism that we see. We can see a little bit of anemia. And then ILD is something that we really think about here. Here you can see that overall the rate of grade 3 or higher treatment emergent AEs was present in about 70% of the patients, but serious treatment emergent AEs were present in only about 15%, and then grade 3 or higher were not that common. And then we've talked about intracranial activity. We have emerging data from Hera Lung O1 that there were intracranial responses observed with this agent with an overall response rate of about 33.3%. I think clinically meaningful. These are patients that are coming in the third-line setting, having failed a couple of different treatment regimens, and I think it's just very reassuring to our patients as well. This drug is being evaluated actively in 2 ongoing trials. So Hera Lung O2 is a phase 3 clinical trial, which is being compared to platinum-based chemotherapy in the second-line setting, so post-EGFR TKI, with a primary endpoint of PFS. And then there is a phase 1b/2 study where patritumab is actually being combined with osimertinib, either in the first line or in the second-line setting in the post-osimertinib, where the primary endpoint is overall response rate as well as toxicity. So I'll stop there and happy to take any questions.
Yeah, great overview, Charu, of the space and where we're heading. Becca, I'll start with you. You know, the question that I had about was on Hera Lung O2. I asked that question not about Hera Lung O1 because I think this is what the future holds, this second line space. Where do you see this drug, Becca, landing? You know, Charu just went over second line versus chemo in combination with OC up front. Do you see a landing space for patritumab deruxtecan in the EGFR arena?
Certainly, that space is quite crowded, right? It's there's a lot going on in the EGFR space. I think things are in a lot of flux. You know, we haven't really talked about the first line space and some of the data and how that may or may not change what people are doing. So I think there's a lot of movement in that space right now. I'll say that in general, these patients who have lung cancer with EGFR mutations, they need more therapy. So I think it's a great thing to have this option as well as many of the other options that we have. And whether somebody is, treated with this in second line, third line, fourth line, I mean, the reality, and this is what I've always said about clinical trials, it's not actually the number of lines that matter. because people can have great performance status and be great candidates for a drug or a clinical trial, almost no matter what line they've been on. But to have another option that is actually a little bit agnostic of the resistance mechanism is a great thing to have.
Yeah. Stephen, I'm going to ask you an unfair question just as revenge for all the unfair questions you ask me. As Becca mentioned, the EGFR space is a mess. It was so clean 6 months ago. We just had OC. That was it. It was a wonderful slide, Flora. Now we've got FLOR2. Now we have Mariposa. Now we have Mariposa 2. Now we have pertuzumab deruxtecan. I want your optimal treatment sequence for a fit EGFR positive patient, given all the data we just have. I want the optimal sequence for you. Again, I'm gonna make it easier for you because I know you need that sometimes.
I do.
We're gonna make it someone in their 50s, never smoker, exon 19, maybe 3 sub-centimeter brain mets. What's your first line and what's your second line? Give me the sequence. We're all waiting.
So it is an unfair question because there's not an answer. Because really, it's not our decision to make. It's something we have to make with the patients. And I think that for most patients, osimertinib is a wonderful option. We know that adding chemotherapy improves PFS, probably won't improve OS because of crossover. Adding amivantamab improves PFS, and there are subsets that seem to get a little bit more benefit, but it comes at a trade-off. You're trading more toxicity. You're trading, attaching yourself to an IV schedule every 2 or 3 weeks. And so it really comes down to the patient's values, what's important to the patient. I think they're all great options. I think that overall, the majority of my patients are probably going to do OC alone in the frontline setting. And where do I see a drug like this landing? Well, I actually think that this will be before chemotherapy. I really am impressed by this agent. Part of it is when we see resistance to osimertinib, we'll see a lot of presentations about rebiopsy, liquid biopsy, targeting MET, targeting RET, targeting C797S. But I think as we're seeing more and more, resistance is very polyclonal and it's a moving target. It's kind of like spinning plates where you target MET and then pretty soon afterwards you see RET, you see BRAF, you target one, you see another. Having something that's so versatile that works across different mechanisms, I think is a really effective way to target this polyclonal resistance. And I really think this is going to move up.
Yeah, great answer, because I think it throws into high relief this intersection. Do we tackle resistance sort of in a broad way, or do we really narrow and define one mechanism of resistance and go after that with some of these targeted agents? And I think that's what we're wrestling with chemotherapy, with the amivantamab story, and with the ADCs. It's a great answer. Okay, so let's move on here. Sure.
I think it's also important to recognize that Becca will talk about this, but I think, TROP2 ADCs also have activity in this setting. And, how do you then, let's say a TROP2 ADC is available with a response rate of 34%, 35% for EGFR mutant. How do you balance that with a 30% response rate?
Right. Yeah.
And how do you sequence them because they have the same payload? So I think we're going to have even more options as we move forward.
Great point, Charo. Great point. Okay, for the sake of time, we're going to move on. Buzzers ready. Name this curve. A lot of thought went into this, and it should have. I'll be very impressed, Charu, if you get this.
This is Tropion Lung O1, squamous.
Wow. Round of applause. This was, of course, the subset squamous curves from Tropion Lung O1. Very difficult. The PeerView folks took out not only the drugs, but the histology there. Only the curves. Well done, Dr. Agarwal. I think there's one more question. Let me make sure. Which of the following was... Wow, that was quick. Dr. Lee, let me just enter the... You're locked in. Let me ask the question here. Which of the following was the most common AE observed with sacituzumab plus pembro in the EVOKE-02 study? Stomatitis, anemia, diarrhea, or nausea?
Well, it's not stomatitis. We know that was the other TROP2, and it's not anemia. It's either diarrhea or nausea. So I'll go with nausea.
That is incorrect. Buzzers ready? Dr. Agarwal. Oh, wait, Dr. Agarwal, I can't see from the buzz. Yeah, Dr. Agarwal?
Anemia.
That is incorrect. That leaves only one.
I have to get on the board.
Dr. Heist.
Diarrhea.
Well done. Round of applause. I think nausea and diarrhea are kind of tied, but I went with diarrhea as the answer. So, okay. Moving on. Answering appropriately, Dr. Heiss, the answer was correctly answering the question. I'll turn it over to you for the TROP2 space.
Great. So TROP2, as you all know, TROP2 is a transmembrane protein highly expressed in lung cancer as well as across a multitude of other epithelial solid tumors. And in general, TROP2 overexpression has been associated with poor prognosis. There is no a kind of selection by TROP2 overexpression, though, I'll say. So in the remainder of the studies that we're talking about, although TROP2 is highly overexpressed, we're not really thinking about selection by TROP2 levels. So there are a variety of different TROP2 ADCs that are in clinical development. Sacituzumab govitecan, of course, has an indication in breast cancer. In lung cancer, it's being investigated actively. And this structure is shown here. This is an antibody that binds to TROP2. There's a hydrolyzable linker. And the cytotoxic payload is SN38, which is the active metabolite of irinotecan. And some of the toxicity we see, particularly the diarrhea, is a reflection of that. IMU-132 was a phase 1 study that really looked at initially dose escalation of this drug across multiple solid tumor types, and then had expansions within various tumor types, including non-small cell lung cancer. And you can see just high-level overview here, the overall response rate of about 17% in the patients with non-small cell, with the median duration of response of about 6 months. The all-cause AEs are shown, with the most common being nausea and diarrhea, as well as others that are seen, including cytopenias, fatigue, and alopecia. Another TROP2 ADC that we've seen a lot of data for is datopotamab deruxtecan. This is an ADC that, again, targets TROP2. There's a cleavable linker, and it's linked to a topoisomerase 1 inhibitor payload. This is deruxtecan, which is the same payload as you saw earlier with both TDXD as well as the HER3 DXD. And again, in a dose escalation and expansion study in all solid tumors, various doses were explored, and then there was expansion in various cohorts. And this shows the expansion in non-small cell lung cancer, various different doses tested. Ultimately, the dose that was moved forward in monotherapy was the 6 mg per kg dose. And you can see responses here ranging in the 25% range, with durations of response that range in the 9 to 10 months range. And safety data are shown here. A different safety profile, even though they're both TROP2 ADCs, they do have different safety profiles. Again, among the most common is nausea, but we also see other AEs that were not seen with sacituzumab govitecan, for example, the stomatitis. And ILD, of course, is an AE that's specifically of interest. And here the ILD rates in the kind of 6 to 10% range. So Tropion Lung O1 was presented at ESMO this past year. And this study, to remind you, looked at patients with non-small cell who were who had received prior chemo and immunotherapy for the non-actionable genomic subset, and for those with actionable genomic alterations had prior chemotherapy, perhaps PD-1, but also prior targeted therapy. There was stratification by squamous or non-squamous, as well as presence or absence of the AGAs, and presence or absence of PD-L1 as a prior therapy, and geography, randomized to Dato-DXd at the 6 mg per kg dose versus docetaxel at Q3 weeks, 75 mg per meter squared. And this is the PFS data in the intention to treat population. In general, a benefit in PFS seen with Dato-DXd with a hazard ratio of 0.75. The response rates you can see here, 26% for Dato-DXd versus 13% for docetaxel. And as Dr. Agarwal pointed out, the PFS curves were quite different by histology. So benefits seen in the non-squamous. This was both the non-squamous with AGAs and without AGAs. But in squamous, the docetaxel arm actually does better here. So an interesting finding, I think one that frankly was a bit of a surprise. And We're still trying to figure out why exactly that is the case. The overall survival data are immature and hopefully will be reported out in the future. In terms of the safety, really no new signals in terms of safety events with datopotamab deruxtecan in this study. I will note that the rates of grade 3 or higher AEs were 25% in Dato-DXd, 41% in docetaxel. But the AEs, as you know, are different. So docetaxel has the typical chemotherapy-related side effects, cytopenias, nausea, fatigue. The Dato-DXd side effects we've talked about. Not as much cytopenia, but certainly GI effects such as nausea, as well as the stomatitis that we see. And again, in terms of the AEs of special interest, we see stomatitis is something that we see with Dato-DXd more so than with docetaxel, the ocular events such as dry eye again. And then ILD, we did know that ILD happened with docetaxel, and it does indeed, but a slightly higher rate that's seen in the Dato-DXd arm. Interestingly, and Dr. Agarwal mentioned this earlier, in Tropion-Lung O5, which was also reported at ESMO recently, this specifically looked at patients with lung cancer with actionable genomic alterations. More than half of the patients in this study had EGFR mutations, about a quarter had ALK, and there were smaller and smaller subsets of the pie with other alterations. And if you look at the data in terms of the group as a whole, response rate of 35%. In patients with EGFR mutations, this is a group of about 78 patients, a response rate of 43%, which is actually quite good in my opinion. Interestingly, ALK, and granted these are small numbers, response rate of 23%. So another kind of thing to add to the mix in the EGFR mutated space that makes that very crowded space even more complicated. So that's some of the second and third line data. In terms of first line, where are we going? There are multiple studies. These are just a couple of examples that are going to be shown here, looking at how can we move these TROP2 ADCs into the first line space. The Tropion-Lung O2 study design is shown here. There are multiple different cohorts looking at Dato-DXd in combination with Pembro, and then also in combination with Pembro and platinum. There have been some early reports. These are waterfall plots showing the responses from Tropion-Lung O2, specifically in all patients and also in those who got it in the first-line setting. And in terms of safety, really, as you would expect when you combine with immunotherapy or chemotherapy, there are some additive toxicities, but no really new unexpected signals in terms of novel AEs that are coming out here. EVOKE-2, and we saw an update on this yesterday at a poster, is another study looking at sacituzumab govitecan here in combination with pembrolizumab, also other cohorts that will combine with Pembro and platinum. And these are some of the waterfall plot data that are shown, broken out into PD-L1 status greater than 50% and lower. The response rates have looked higher in the higher PD-L1 as compared to some of the lower PD-L1 settings. Overall, these first-line studies are very interesting. I think the numbers of patients in all of these are actually relatively small, and it remains to be seen exactly how these drugs might be incorporated in the first-line setting. And going back to safety here, again, kind of additive toxicities that we see when we combine immunotherapy with a TROP2 ADC, but no particularly new or concerning signal of any novel AEs here. Multiple other phase 3 trials in this space shown here are some of the phase 3 trials. There are many others actually looking in the first line in combinations with both IO and chemo IO. We talked about Tropion-Lung O1. There's also EVOKE-01, which is a similar study comparing sacituzumab govitecan to docetaxel that has not yet been reported yet. And so, a lot that's in development and a lot in flux in the TROP2 space.
Becca, great overview of a very crowded space, getting more crowded by the meeting. Charu, I'll start with you since you were locked in on that Kaplan-Meier curve for squamous cell for the Tropion-Lung O1. Are you ready to use datopotamab deruxtecan for patients with non-squamous histologies in the second line? Becca talked about there being potentially more pronounced or having a more pronounced PFS and potentially an OS in that non-squamous patient population. Is this something you're ready to use, or do you still have pause?
Yeah, so I think that's a really good question. So if you look at the overall trial, we know that Tropion Lung O1 as a whole was a positive trial. The hazard ratio did meet its primary pre-specified endpoint. And if we were to then start to look at differences, they clearly emerge with squamous 1.38 hazard ratio for PFS, patients doing worse with DATO, so I would not use it for those. But then when you look at the non-squamous histology, you're seeing a hazard ratio of about 0.6, 0.63. And, it's intriguing to see that you're actually seeing a benefit there. Maybe most of that is being driven by those patients that have the actionable genomic alterations. But even if you take those patients out, you're seeing a hazard ratio of about 0.7. So I do think that using it in the second-line setting would be reasonable. Compared to docetaxel, when we look at all-cause AEs or all AEs, they were overall less with Dato-DXd compared to docetaxel. And ILD is one thing that was higher with Dato-DXd compared to docetaxel, but all others were lower. So I do think that if we start to become a little bit more cognizant that these drugs can cause ILD and pay a little bit more attention to the 5 S's that Stephen talked about, screening these patients, looking at CAT scans, using a multidisciplinary team, and really not waiting and treating pretty quickly with steroids, I think we should be able to safely use these drugs. It's just a matter of recognizing the ILD. But I think that was a long-winded answer. Ben, you asked if I would use it. I think I will.
It's a great job. I think you answered it comprehensively, and it needs to be answered comprehensively. I mean, I look forward to this. I think, we'll have to see how the FDA views the non-squamous histology and whether this gets approved. But I think I'll be an early adopter of this with mindfulness on proactive management of AEs. Stephen, you and I had a conversation last night about whether these ADCs can replace platinum up front. Becca presented data from Tropion Lung O2 and EVOKE2 showing activity with these ADCs in the first line in the treatment-naive setting. Where do you see this going?
I actually don't have as much of an emotional attachment to platinum as I think a lot of our colleagues do. And while we're sort of grown up to stress the importance of platinum, when we look at our true goal here, it's not to push response rate. I think that in 2023, we're more sophisticated. We want survival. And in the frontline space with IO, the goal is to get more long-term survival. The goal is to really get the tail. When we look at preclinical evidence in terms of potential synergy between different cytotoxic agents and immunotherapy, I think the weakest evidence is with platinum. The response rates of EVOKE2 are pretty comparable, a little bit higher numerically than every PD-L1 subset in Keynote 189, and that's without the platinum. So is the platinum adding more than just our own comfort and dogma and tradition? It's certainly adding toxicity, and is it getting more people to the finish line? I'm not convinced that it is, so I'm pretty okay dropping the platinum.
Well, interesting. I heart platinum. So we'll have to see how this works. I will see, on the front line, but great points. We'll have to see. I mean, we do have this attachment to platinum. It's been around from the 70s and 80s, obviously, and whether we can replace that with a more novel compound, chemotherapy 2.0, we'll have to see.
Yeah, but I think that the management of lung cancer has changed since you were practicing in the 70s and 80s. We'll have to see this going forward.
All right, let's move on. Buzzers ready? I was originally discovered as a pathway and published in Nature in 1980. Let me finish the question because I spent a lot of time on it. I was originally discovered as a pathway and published in Nature in 1984 and have recently emerged as a potential therapeutic target for the ADC ABBV-399. What pathway am I? Dr. Agrawal.
CMET.
Incorrect. No, I'm sorry. I'll have to go back. That is, the MET pathway is correct. Sorry. I heard CCAM for some reason, but it was CMET. I'm sorry. So very well done. Okay, last question here. Are you ready? Name this ADC. Charu.
Dato.
That is incorrect. This is tough. I'm sorry. It could have been. Name this new ADC. Stephen.
I want to say 4, but I think it's 3.
It is ifinatamab deruxtecan. I just want to read the answers because I spent a lot of time on these two. But I know. I'm sorry. PeerView made it even harder. Patritumab deruxtecan is one. Datopotamab deruxtecan, ifinatamab deruxtecan. And just so you're clear on the pronunciation, number 4, it's levimitamab osemtine. It's not that. So it is ifinatamab deruxtecan, if I'm even pronouncing that one correct. I'm going to spend the last 3 minutes quickly going through the emerging ADCs, and then hopefully we have like 3 minutes to get to some of the key questions. Multiple other ADCs are currently being looked at. We touched upon the ones that have the most traction. Tuzumab riftansine is a ADC targeting CEACAM5. I'm sure you've heard about this as emerging. There is data on this compound, specifically in patients with non-squamous non-small cell lung cancer who have high expression of CEACAM5, and there's an interesting way that you can measure this. Small number of patients, about 64 patients treated with high expressing non-small cell lung cancer, CEACAM expression non-small cell lung cancer, and 28 patients with moderate expression. The response rates are modest at best, I'd say, but we need more data. The high expressors, the 64 patients, had an objective response rate of 20%. This is a highly pretreated group of patients, but it's signal finding, and certainly we'll see how the data pans out in future studies. We need to be mindful of some of the interesting AEs we're seeing with this compound, including the corneal AEs or the keratopathies, and how to manage these. And this is just an example of these corneal dystropathies or keratopathies and how to manage them. c-Met overexpression, that was the right answer. Sorry that I dashed you a little bit there, Charu. But that MET pathway is certainly at play in lung cancer. Like HER2, MET alterations come in many different shapes and sizes. We're familiar with MET exon 14 skipping alterations, but when we start looking at the ADCs, maybe we start looking at c-Met overexpression by IHC. Tocilizumab vedotin is a first-in-class anti-c-Met ADC. And we've got interesting data that's come out. It's fairly old, and we're learning more and more about this, but 3 separate cohorts evaluating tocilizumab vedotin, patients with non-squamous EGFR mutant that were c-Met high or intermediate, patients that were non-squamous EGFR wild type that were high or intermediate, and then squamous cell, all treated with tocilizumab vedotin, 1.9 mg/kg every 2 weeks. This was, again, patients who were highly pretreated. And interesting, the c-Met high, it's a busy slide. I've looked at it many times to whittle it down very quickly. But the non-squamous EGFR mutant c-Met high seem to be non-squamous EGFR wild type c-Met high seem to have the highest response rates here. It just begs the question if c-Met is going to be a bona fide biomarker, if c-Met overexpression or MET overexpression is going to be a bona fide biomarker for this drug. Are we going to use it like we're looking at it in terms of patritumab deruxtecan, datopotamab deruxtecan, where IHC doesn't really make a difference? Ifinatamab deruxtecan, we've heard a lot about this drug with small cell, but we've had interesting data cuts in small patients with non-small cell. This is a fully humanized anti-B7H3 IgG1 monoclonal antibody, a cleavable linker, and the familiar topoisomerase 1 inhibitor payload. There's been dose escalation and dose expansion of this compound, both in small cell and in non-small cell. I'll just focus in on the squamous cell non-small cell lung cancer patients. There are 13 patients, 4 out of 13 response, so a 30% response rate. Small numbers here, but we're starting to see a signal here. And we've, of course, looked at this in small cell too. The response rates seem to be a little bit higher in small cell. And I think we're begging for new therapies in small cell. Perhaps this ADC will land front and center very soon in the small cell lung cancer space, given how much we need to move the needle, specifically in the second line space. Toxicities associated with this compound are usually GI related. We've seen some infusion related reactions as well, but overall reasonably well tolerated. But there are treatment emergent adverse events that we do see that did lead to drug discontinuation and interruption and reduction. Similar to the other IHC stories with other compounds, Doesn't seem like IHC or B7H3 expression made a difference. And again, it's going to beg the question, is IHC a marker we're going to be using for all of these ADCs? So we'll start there. We've got 4 minutes left. I really wanted to touch on and engage the panelists on these 3 questions. Biomarker selection, is it a one-size-fits-all? Are we really going to narrow the patient population for each of these drugs? Becca, I'll put you on the spot first. Where are we heading with these ADCs? Do we need more biomarker enrichment? Are you okay right now kind of saying, look, IHC doesn't make a difference. We should use it as an all-comer approach?
So, that's a tough question. So clearly there are sometimes some biomarkers where it makes a huge difference. So if you have a HER2 mutation, for example, then, it's easy. Trastuzumab deruxtecan is approved and the way to go. Beyond that, obviously none of these have real biomarkers. Would it be nice to? I would love them. If I knew that if I gave something, I could expect about 80% of the time this person's going to get a response, then it makes the choice very easy. And you really, as much as we want to use everything we can, as you're treating a patient through the course of their multiple treatments, you want to give them the best benefit you can at the time when you're selecting that drug. And so running through a lot of things without really knowing what's going to happen is tricky and hard to do. So I would love for some of these to have better biomarkers. At the same time, they don't right now. And is there a need for more drugs that have activity for all patients? Yes, there is. So, it's a bit of a mixed answer. I think, of course, the more drugs we have, the better. There's more potential benefit for people. But to really help us select so that each particular patient actually gets the most benefit with the least toxicity at every point that you're making a treatment decision with them, it would be incredibly helpful to have better biomarkers for all of these drugs.
Yeah, I think we've gotten lucky with HER2 mutations as a bona fide biomarker. Whether we can recapitulate that with other ADCs, with other histologies is unclear. Charu, I'll just go down the line here. Where do you see these ADCs fitting in? I mean, it's a broad question here. Are we going to move these up front? Are you happy with where they are in the second line? Where do you see them moving? Is there opportunity in early stage disease? I know NeoCOAST-2 is looking at neoadjuvant ADCs. Where are we going here?
Yeah, I think they'll continue to move earlier. We're seeing, obviously, the first-line trials starting to read out in smaller subsets in the metastatic space, and then trials being conducted now as we speak in the early stage setting. I do think that your third question of we just have to be proactive to manage these toxicities, but I think they are here to stay and will be our next option to use.
Stephen, I'll leave you with bullet point 3 question here. Are we being proactive enough with these different ADCs? I mean, do we need a different algorithm or paradigm, better engagement with our subspecialists, dare I say, our ophthalmologists? How do we do this moving forward?
Yeah, I think we'll get there. When we look at the rate of severe adverse events, they're lower with the ADCs than docetaxel. They're just ones we're not as comfortable with, but that'll come with time. So we'll focus more on the AEs and we'll get better there.
Well, listen, I want to thank all of you. I feel like I got to know you better, so all on a first-name basis here. Becca, Charu, and Stephen, thank you so much. It's my honor and privilege to announce the winner. It's a tie. No. So, what I would say is that I will present to you, one of you will have to accept this. Go ahead.
I actually think that the cartoon, because the DAR is the same for datopotamab and ifinatamab, I think Charu should have got half a point for that.
I think Stephen is thinking ahead of the curve here. I would agree that Charu should be the winner here. Let's give it up. Charu, I think Stephen may have known this, but I want to just present to you what I call the reward and the award for this, what I call the Sunday Chicago O'Hare headache. Here you go. You thought you were carrying on, but you're checking in. Thank you all.
Thank you for listening. Download materials and complete the post test for instant credit at peerview.com/YXT860. This activity is supported by independent educational grants from AstraZeneca and Daiichi Sankyo Incorporated.